Testing 1 2 1 2. Test 1 2 1 2.
Can I get that light down, perhaps? Or no?
There's no way I get this. There's no way. I used to have it organized. I couldn't shoot the thing home.
What about a pointer?
There's usually one up here somewhere.
Oh, just sit there. No. Maybe the batteries.
Let's see if that's. Oh, there's got to be a USB thing.
So I had one of those surgical site infections.
Let me go back and get her. Tell her.
All right.
Nope, not good. Because it ended up being life-threatening. But yeah, I was survived.
She's going to come.
Okay. Just don't trip over that one. Thank you. Thank you. Okay.
Just remember, you'll need to stay behind the podium
Okay.
because I've got your slides next to you. If you don't, you'll walk behind.
Got it.
Whenever you get ready.
All right. Good afternoon, everybody. I'm going to be talking a little bit today about surgical site infections. My name is Herrick Siegel. I'm an orthopedic surgeon over at UAB. And I have some disclosures that I'm required to inform you of, that I'm a paid consultant of some of the implant companies in the area. However, none of the products I'll be discussing today are pertinent to the disclosures. So my interest is in orthopedic oncology as well as infections and total joints. I did a residency out in Los Angeles at USC. Spent some time on a dedicated service that was specializing in bone and soft tissue infections while out there by a multi-specialty team that took care of patients with complicated infections such as necrotizing fasciitis, and soft tissue management was required for many of the patients with large blast injuries from shotguns and such. I do some research in surgical outcomes and limb salvage. I have done in the past for chronic osteomyelitis and orthopedic oncology. I was trained in a fellowship at Mayo Clinic with orthopedic oncology fellowship and adult reconstruction. Finished that about 17 years ago. Performed limb salvage operations there, complex joint revisions, pelvic resections on patients with bone sarcomas and soft tissue tumors. I did a residency, as I mentioned before, at USC, and did a fellowship in oncology, and then have been specializing here in Birmingham at UAB for the past 17 years. I'm actually the only orthopedic oncologist operating here in Alabama. So I do also do complex joint surgeries as well, including the hip, knee, shoulder, elbow, and do about 800 to 1,000 surgeries a year at UAB. So there's a lot to learn in orthopedic infections in general, as well as surgical site infections, and as I mentioned before, most of my experience is in orthopedics. However, there's a great deal of crossover into other subspecialties of surgery, such as plastic surgery, vascular surgery, and other areas. And we really know very little about infections. Much of what we practice is primarily based on theories and small studies that are fairly non-scientific and mostly opinion-related and speculation. It's very difficult to identify a lot of the specific causes of the infections, like where did it happen, when was the actual event that caused an infection? Was it before the surgery, during the surgery, or after? And there's a lot of healthcare costs obviously associated with not only the diagnosis of infection, but treatment. The treatment for infections, as many of you know who have seen patients with infections, is very morbid. It's mentally detrimental, causes depression in many patients. It's often disabling, and many patients will lose their jobs, homes, insurance. Sometimes it affects their family life. Success is often unpredictable, and recurrence is certainly possible during the lifelong of the patient. Places a strain on the doctor-patient relationship if one occurs, and it results in poor patient outcomes and, in some cases, malpractice. So I deal with a lot of high-risk patients, and probably the highest-risk patients perhaps in Alabama and the Southeast, doing orthopedic oncology, as many of these patients are immunosuppressed on either chemotherapy, have had radiation, or have multiple comorbidities. I also see patients that have had up to 10 to 15 joint revision surgeries before they come to see me for a limb salvage operation. It's not uncommon to see patients with end-stage organ failure, either pre or post transplantation. Many of these patients are on immunosuppressive drugs, and then there's patients that have chronic viral infections such as HIV, which are immunosuppressed as well. Long-term nursing home residents are also fairly high risk for infections in general, and many of the patients we see have histories of other infections involving urinary tract or lung infections. Probably the most complex patients are those on chronic anticoagulation. These require management in the pre-intraoperative and postoperative period, which requires often a transition from a chronic medication such as Coumadin to Lovenox, and then back onto Coumadin with a lot of overlap in treatment to make sure that the patient doesn't develop blood clot. And there's patients that are on dialysis, which have fairly high risk of infection as well. And of course, morbidly obese patients, which we consider over 40, and then the super morbidly obese, which have BMIs over 50. Not to mention some social aspects of patients' behavior that also place them at higher risk for infections, such as a history of depression, smoking, IV drug use, and then chronic narcotic use, which of course you've heard of the opioid epidemic, and we do everything we can. However, it's difficult to wean some of these patients from narcotic use. So we all talk about optimizing the patient's comorbidities before we operate, and in some circumstances we have the opportunity to do this. And I think that these four areas are probably the most closely looked at, with diabetes, hypertension. The control of these two chronic illnesses preoperatively is helpful. Correction of the anemia, and then cardiovascular workup with cardiology clearance. We know that preoperative antibiotics prophylactically is important. The timing of this is very crucial, depending on what kind of antibiotic you're using. It can be given as much as a couple hours before the surgery, or in some cases 1 hour before the surgery, such as in vancomycin. Skin conditions are also important, obviously, to look at, such as cellulitis and potential surgical site infection prior to an elective procedure. And other sources of infections also are important to at least identify and document. The chlorhexide scrubs and alcohol scrubs are helpful topical antiseptics. And at our institution, we use mupirocin preoperatively on all patients as a decolonization for nasal passages. This helps reduce the load of MRSA for that particular patient, and in theory helps reduce the risk of MRSA in the hospital. So what can we do intraoperatively? Well, many of us understand the importance that do surgery on minimizing soft tissue trauma, and obviously having a surgical technique that does this is crucial. And this is particularly important in trauma patients, where not only is the bone sometimes in orthopedics compromised, but also the soft tissue envelope around the bone. And it's not unusual to have dysvascularized tissue that either requires debridement or is contained around a fracture. Shortening the operative time is important as well, and this has to do with being prepared for the surgery, having the appropriate instrumentation available, and having the staff around you that is knowledgeable about your surgery. And reducing OR traffic. One of the problems we have at academic centers with teaching is that a lot of people want to be in the room at the same time. We have medical students, residents, fellows. Sometimes there's OR staff that's training. So I'll have a visiting even physical therapist in the operating room from time to time. So there's quite a few people in there, and we do try to minimize the traffic. So if they come in the room, that basically they have to stay in the room. They can't just keep coming in and out. We try to reduce the use of tourniquets, particularly in the distal extremity and in the for knee replacements. I believe this does have a detrimental effect to not only bringing the antibiotic during the surgery to the site of surgery, but also ischemia. Certainly not very healthy for soft tissues in general to protect themselves against infection during the surgery. We try to use adhesive dressings around surgical incision sites to protect and create a barrier on the incision. And we also try to keep the bacteria that are basically being secreted with the hair follicle during the surgery. So we try to protect the secretions that naturally occur where bacteria can come from. And so we coat the skin with Ioban. Foleys are used very sparingly. We try to avoid the use of that due to the increased potential risk of urinary tract infection, and hair removal is done at the surgical site as well. Recent advancements in arthroplasty with the use of such agents as tranexamic acid, which is a IV given a medication that reduces the risk of hemorrhage during the surgery and assists with blood clotting cascade. Obviously, meticulous hemostasis is important as well. So as we try to minimize hospitalizations, many of you have already heard that we're trying to do outpatient total joints in the country, in the U.S., and this is very popular outside Alabama and is growing popularity, I imagine, in Alabama as well, as we'll be sending patients either home within 24 hours of the day of surgery. I believe this is shown to decrease the risk of nosocomial infections. There are some other risks involved with that, which we do have to carefully select which patients may be good candidates for outpatient surgery. However, it obviously does reduce the risk of in-hospital infections. We're also likely going to decrease the use of rehab centers and skilled nursing as bundle payments come to Alabama and as part of the Southeast. We're going to see more and more home management of patients. We use sealant dressings over the incision. This reduces the changing of dressings that frequently can occur and potential skin site infections and contamination. We aggressively treat potential infections. It's much better to treat a suspected infection than one that has occurred and that we're somewhat ignoring. Obviously, pulmonary toilet with incentive spirometry, early mobilization, and using either aspirin or another anticoagulant to prevent DVT after the surgery remains important. So we have education programs now for joint replacement patients and others, and we discuss with them things that we really had never really brought up in the past, such as their own personal hygiene, their home situation with home hygiene, how they're going to restrict access to their pets. It's not uncommon to hear a patient that tripped over their dog right after the surgery, or the dog was doing something to their dressings. So it's important to have their home cleaned. The preoperative surgical scrub is now recommended, and we do arrange for home assistance as early as possible for some of those patients that live by themselves or have difficulty getting to appointments. We do encourage primary care doctors to see the patients prior to surgery, but nevertheless it is ultimately important that anesthesia is comfortable with the surgery themselves, and we have a pre-op appointment with anesthesia. We do discuss of surgery and including the infection and possible need for early intervention sometimes with some patients who are at very high risk for infection. It's very difficult for me to quote you an infection risk. We don't really know. We do know that if you're a relatively healthy person with minimal risk, a total joint for the first time would be about a 1 to 2% risk of infection. But we don't want any surprises. We do discuss infections with patients, and the worst outcome probably for a patient would be that you never mentioned the infection to me. Why do I have an infection? This never came up before. Why do I need treatment? So there are a lot of things on the physical examination that we look at, and some things we are concerned about and others perhaps not quite as much. It is fairly normal after an operation to have erythema. It's not uncommon for me to hear from home health care nurses and such that patient's incision is red. Well, during the course of physical therapy, the incision will become red. It's a very poor diagnostic sign for infection. Drainage, however, is something that is more important. And there are some patients where we expect some drainage, and only the doctor themselves know to expect this, so it's a little difficult for home health nursing to determine which ones are acceptable and which ones are not, and I think these are reasonable calls. The top left picture there is an eschar, and that is something that occurs with poor vascularity to the skin. In many situations, this eschar will resolve just as a scab, and it will contract, and eventually the eschar will be removed slowly over time. And sometimes this is more or less a biological dressing. It doesn't necessarily need to be removed and aggressively debrided. You can see there the remainder of the skin is fairly normal in its appearance and does not appear to be red, swollen, and draining. So sometimes it's easy to recognize infections, and sometimes it's not so easy. And they all don't come in like this with their knees sticking out of their implants sticking out of their knee. But it is important to do an appropriate workup of many of these patients and get a good history, physical exam. And there is blood work that we rely on to determine whether a patient's infected or not, such as the CRP, ESR, and a CBC with differentiation. If these prove to show elevation or concern for infection, we'll then proceed with getting aspirations of the knee joint. As I mentioned before, there are various degrees of patients that are higher and higher risk, such as the sarcoma patient that gets a resection of their hemipelvis and I do a custom reconstruction so they can ambulate again, or a patient with neurofibromatosis who has significant redundant soft tissue and skin that are at high risk and have had a prior amputation previous to a hip replacement. So there are many comorbidities, though, that we can look at, and there are clinics around the country now, and particularly academic centers, that will create pathways for these patients to go, and doctors specifically that for us to refer them to deal with such things as morbid obesity and the chronic diseases that are listed there. Hemoglobin can be corrected as well. It's not necessary to do blood transfusions, but for the most part, iron infusion therapy can be helpful, and in some cases, erythropoietin can be used, particularly in patients that are refusing blood transfusions. Very helpful to get the hematocrit above 40, and many of these supplemental medications can help enhance their hematocrit preoperatively. As I mentioned before, infections can occur anywhere, so we do want to optimize the patient to limit their infection, and dental hygiene in particular is one of those where patients will sometimes get tooth extractions prior to surgery to reduce if there's any evidence of an infection. So intraoperative variables, as I mentioned before, we minimize the soft tissue risk. We try to make the surgeries as short as possible, the bleeding as little as possible, and the room traffic as minimum as possible. And then postoperative, as I mentioned before, try to reduce the risk of hematomas. Try to maintain dead spaces, which are areas where hematoma can collect. We can use drains or just compression. This is particularly important in the morbidly obese patient. Blood transfusions, we try to decrease the use of drains because this has shown evidence that it increases the transfusion risk postoperatively as well. And then shortening the hospitalization. So there are differences between early versus late total joint infections, and one thing that we do look at is around 4 weeks. There's a coating that basically forms around the implant that protects the bacteria, and this occurs around 3 to 4 weeks after the surgery. So we like to see if patients can be identified early. We're able to retain the implant components except for those that are modular. So there are some components within the total joint itself that can be easily exchanged, and that is done if it's an early infection. For later infections, unfortunately, the implants themselves often require removal. So these can be very difficult at times to remove. These can be late infections where there's already bone ingrowth occurring around the implant, so then we have to sometimes osteotomize or cut the bone to remove the implant, and this can be fairly morbid. So component removal and then spacer placement. So these later infections will temporarily place a joint that is not meant to be permanent. It's a spacer, and then at a later date, once the infection is cleared, we go back and remove the spacer and put the final implants. But there's a huge difference in morbidity and even in mortality between the early and late infections. It's much less morbid if the patient's dealt with acutely, and we can just wash the knee joint and change some of the plastic components. So patient selection and really who is too high of a risk, it's really hard to draw a line. Even with BMI, there are some surgeons who will say, I don't operate on patients with a BMI over 40, but is 41 too much, or is 42 too much? It's really hard to really draw a line. We kind of have to look at the overall patient and just determine, is this patient really at too high of a risk for surgery? So ultimately, it's the surgeon's decision to decide whether to proceed with the operation. And then if complications do occur, it's important that that surgeon either knows who to refer him to or to deal with those complications. So how bad can things get? Well, in many situations, a simple operation such as a fracture or a knee replacement can really turn into a series of dramatic events that can really compromise a patient's life and their ability to ambulate and have independence. So this is not well projected. This is a total femur replacement, but in some cases where the bone is just so poor that we can actually replace the majority of long bones and substitute for those very poor structured bones with implants. This is what it looks like intraoperatively. It's a little unusual, if you've never seen this before, a little unusual. This is the knee joint down here. This is the total femur replacement with all the muscles dissected away from the femur. And we can actually replace long bones, majority of the pelvis, and most of the tibia with implants actually. So it's, we've come a long way with the development of products. What we used to do 20, 30 years ago is use bone, cadaver bone, for a lot of these reconstructions, and over time the grafts, the cadaver grafts would just fall apart and the patient would develop these large fluid collections, eventually infections, and then they'd get amputations. But fortunately with modern implants, and this again is a knee, and this is the knee joint here, and this is what's called a rotating platform implant, which we are able to stabilize without ligaments so the patient can ambulate. This is a tumor patient. We're able to bypass the vessels which are involved with their tumor and save the extremity. But these patients, as you can probably tell, are pretty high risk for infection. So we all go in there with a specific plan, and then we have to sometimes make adjustments. And I'm fortunately working at a center where I have access to pretty much any implant and things that I need for most of these operations. As we look at more and more complications, they can occur mechanically as well. And mechanical complications is basically when the implants just kind of fall apart. It's kind of catastrophic failure. Even in these situations, it's a fixable problem. It generally happens in very morbidly obese patients that have large spaces where the implant can disengage and then rotate within their own knee. And in this case here, although this looks like a fairly happy component, I can tell you the patient is not as happy as the smiley face the component's making, and often we have to use soft tissue flaps to cover the metal. And patients can actually live for a long time with these before they even come in for help to the right setting. So metallosis, you may have heard of metal debris in some of the components. This can actually occur around hip and knee, and any metal component really, even in trauma cases where there's plate and screws being used. But they often mimic infections, and in some cases you get metal debris and an infection. And what you can see here is this black staining. This is the knee joint, and this is black staining all around the knee. And as metal rubs up against metal, it basically elutes all these particles and stains the soft tissue and bone, and over time your body reacts to that and creates inflammatory response, and then the bone over time gets essentially eaten up, so that there's less and less bone to work with, making it somewhat challenging. We do have lots of different types of styles of component reconstructions. I'll just go over this briefly, but you can see here when we start doing revision surgery, we get up into the area of anywhere between 5 and 10% infection rate for revisions. And in those patients that have prior history of infection of the same joint, it can be as high as 20 to 25% risk of recurrent infection in many of these patients. The organisms tend to be the same, although over time some newer organisms have become more common than years past in joints, but staph infections still remain the #1 infecting organism that we see, and then followed by many others. But nevertheless, staph aureus, staph epi continue to be the main problems. So we can do whatever we want to the joint, but if the soft tissue envelope, so this is a knee here on a patient that's been multiply operated on, and then here's a patient on the other side with multiple sinus tracts draining from their knee. The soft tissue envelope is so critical and very, very difficult around the knee, because as you know, it's pretty much a subcutaneous joint. It doesn't take long to get down to the knee. And patients will develop sometimes these large abscesses around the front of their knees, and this is a result of chronic infections of their joints. So fortunately over time we've developed some techniques to try to reduce the risk of infections, particularly along these large metal implants where the infection rate is fairly high. And what we can use is calcium sulfate, which basically creates a paste, and then we can place antibiotics within this paste. And then over time, the antibiotics slowly elute around the implant, or they come out of the paste, and interestingly, the paste will be gone in about 6 weeks. The body resorbs it. So we can use this calcium sulfate as a delivery system, basically, to bring antibiotic, or really whatever we want to use, but more commonly right now we're using antibiotics. This is a distal femur replacement. For those of us that do orthopedic oncology and limb salvage procedures, this is pretty much the bread and butter of limb salvage surgery, where the knee tends to be the most common area where we deal with this, and these implants are used not only for tumors but also for periprosthetic fractures, particularly in the elderly. We were years ago trying to fix all these fractures, but it does appear that in elderly patients 75, 80 and up, they can get immediate weight bearing on these implants, and it's very important to early mobilize them. And some of the fixations that were performed previously, where they were non-weight bearing for a year, was very morbid for them, and they were doing fairly poorly. So the immediate activity and weight bearing for these kinds of patients is important. So what's more challenging, and in some cases where the proximal tibia is replaced, there's even less soft tissue around the top of the tibia. So in these particular cases, it's real important to make sure the soft tissue envelope is viable, and we're able to do transfers of muscle to protect the components that are underneath the skin. So in this case, you can see some of the metal coming through the surgical incision, and it's important that we provide that implant an appropriate environment so it can heal, do well, and allow for the resistance for infection. So we do have signs on the x-rays when infections are occurring. So this patient was referred to me from after being performed in another state, and you can see here a lot of changes in the bone. This is not normal, so we do look for signs such as massive heterotopic ossification progressing, and changes within the bone that indicate chronic osteomyelitis. So it does appear, and we do hear more and more, how PJIs, or periprosthetic joint infections, are on the rise. I think that we're doing them more commonly, and we're certainly up as a group living longer, and patients are living longer with chronic diseases. And as the management of the chronic diseases become better and better, we have more patients that have these diseases, and the infection rate appears to correlate well with the diseases that people are being treated for, such as cancers and diabetes and other immunosuppressive type disorders. So what we really don't know is, because the treatment's so variable, and the surgeon's preference is variable, what is the standard of care for most of this? And there's a lot of controversies in the joint infections, and I imagine with any surgical subspecialty, we really don't have a great specific plan, and it really depends on your resources and what's really available. Because we do know that the government and insurance companies are penalizing hospitals and physicians for perioperative joint infections. And if you have a return the patient to the OR in the first 90 days, there will be penalties on reimbursement. So one of the questions is, when do you bring a patient back that has drainage? Some of us do it at 7 days, some at 14, some never. Some just wrap it and put them on oral antibiotics to suppress it and then hope that it doesn't come back. Infections before, 4 weeks post-op, what is the real good treatment for that? What's the best options for that? And if you look at surgeons across the country, there's various ways of treating it. And in Europe, they even treat it differently than the United States, so it's really highly variable. And then there are those controversies over treating chronic and late infections. And then sometimes we do surgeries and we do a culture during the operation where we're not expecting an infection, and then the culture comes back positive, and what do we do for those? So I won't get into a lot of the details of this, but basically what forms is this biofilm, or glycocalyx is what it's called, and it adheres to the metal. And when we treat the patient with antibiotics, we can't get the antibiotic to the bacteria. So once the glycocalyx is formed, things kind of change as far as what our options are. And until we can get a substance or a medication that removes the glycocalyx from the implant, our option is to remove those implants. we really don't have a great method. There are things in the works, and every time I speak to a different implant company, they're coming out with a new coating that's going to change the world. So hopefully that'll happen soon, but I don't know for sure. But there's definitely a lot of hope out there, and I always hear the word game changer all the time when we talk about infections and what they're going to coat their implants with. But I hope that happens, and I hope we get rid of this biofilm problem. Just getting back to some of the modifiable risks, because I think these are things that we all look at and deal with, and I think malnutrition is one that no matter what the patient looks like, whether they're obese or even cachectic looking, I think malnutrition is seen in everyone. And I think pre-screening with albumin is important with total serum leukocytes. It's important to take a look at that in patients with HIV. We'd like to take a look at their viral load and their T cells and hemoglobin A1C. For patients that are on chronic narcotic use, there are pain clinics out there. It's very difficult for orthopedic surgeons to wean a patient off preoperatively of narcotics. I think we do need referrals and assistance with that. I think it's kind of unrealistic for me to say to a patient who's been on pain medicine for 10 years, stop your pain medicine, I'll do your knee replacement. And then, of course, referrals to dentistry for modifying risk for the dental infections. There's a lot of stuff that we see, and this is probably the majority of my patients have these non-modifiable risks. I'm not going to be able to cure their liver disease. If they're on dialysis, they're going to stay on dialysis unless they're getting a kidney transplant. Many of them have autoimmune diseases where they're on medications that are immunosuppressants. These are things that we just have to document and deal with, and there's really not a way to modify those. But it's important to recognize that these are the primary organisms. We got to make sure that we have coverage for those preoperatively, intraoperatively, and these are the organisms. One thing that is a problem is fungal infections are extremely difficult to treat in total joints, and certainly removal of all components with aggressive debridement is important with Candida and other fungal infections. There are implants that are developed to improve patient care between the time the infection is identified, the components are removed, and the actual real implants go in during the spacer period. And I think as implant companies are developing more and more spacer-friendly components, in a sense that I think we can make the patients undergoing treatment for infection more comfortable and have them resume their normal activities even during the course of treatment for infection. So I think one focus is improving that treatment period where patients are having significant morbidities and problems from their infections. So two-stage revisions, this is a lot of data here, but primarily that's the gold standard, and there are surgeons that'll do a one-stage operation where we basically remove everything, debride it, change all the instruments, our gloves, and then place implants right back in and then treat them with antibiotics, and that's more commonly used currently in Europe, but it is something that tends to be slightly gaining popularity in the United States as well. So as I mentioned, there are some things we can, again, do medication-wise in terms of looking at CRP and ESR. Routine urine culture is not recommended, but if there are symptoms, it's important to have a urine culture done. And then administering the cephalosporins through an IV prior to surgery. 30 minutes is for orthopedics, and then within an hour for vancomycin. You need to give vancomycin about an hour to circulate. And then this is hard to see a little bit, but there are some controversy out there regarding vertical laminar flow operating rooms, whether this is beneficial or not. We really don't have a great way to document even limiting flow of people in and out of the operating rooms. This is just a theory. Minimizing OR time. We all try to get in and out of the room, but really, can you do that? And then, of course, tourniquets have been around forever. Is it really making a difference? We really don't know that 100%. It does appear that minimizing the tray usages, so surgical trays, is important. And it seems that reducing bear huggers, which is a way of heating the patient and then circulating that air around the room, likely has an impact on infection, but we really don't know that. And for those of us who do total joints, we wear these kind of spacesuit-looking outfits that are ventilated helmets, and to be honest with you, we don't have really good studies showing those make a difference either. There are some benefits to holding antibiotics if we're looking for a culture that we don't know a bacteria on, but for the most part, we try to give everybody antibiotics preoperatively, regardless of whether they're infected or not, unless we really don't have an organism. It does appear that hyperglycemia is really important around the perioperative period in particular. So even if the hemoglobin A1C is normal, if they come in, patient comes in for surgery with a glucose of 300, that puts them at a very high risk, much higher risk of infection. So even if they're well controlled, still is important in the perioperative period, and this can increase hospital stay as well. I saw this statistic that almost half the patients with hyperglycemia don't have a previous diagnosis of diabetes, so it is important to screen all those patients. So then I hear a lot at orthopedic meetings about delaying surgery and whether we should take a patient that's super morbidly obese and say, go lose weight and come back in 6 months, and then if you lose the weight, we'll do your surgery. And there are studies showing that it really doesn't help very much. Bariatric surgery can be considered, but for the most part, most patients don't lose a lot of weight preoperatively. And as I mentioned before, obviously operating on someone with an active infection is probably not the best idea. No prognostic studies have shown that modifying these risks really make a significant difference in joint infections. We do have these theories. We have small studies indicating that there is a reduction, but nothing really, no randomized, double-blind or any kind of study like that that would show us strong evidence that even optimizing some of these patients would really eliminate their risk or reduce it significantly. So does delaying surgery really help the patient reduce the risk of infection? We don't know that for certain. Does it decrease overall readmission rates? So when we send patients home, by delaying their surgery, are we also decreasing the risk of them coming back for more operations? We don't know that yet. Do these interventions improve the outcomes in high-risk patients? We really don't have a study showing that optimizing them also gives them better outcomes. And is it cost-effective to delay surgeries? We really want patients out there waiting around for surgeries, and then perhaps even getting sicker and then coming back in for their operation. So it's easy to advise, but very tough to enforce. So I can tell every patient that comes through that you got to stop smoking. You can't smoke anymore. You're going to lose your leg. Something's going to happen. You're going to get an infection. But it's really tough to enforce that. And pre-op tobacco cessation programs, usually about 6 to 8 weeks beforehand, can be helpful and likely reduce the post-operative complications. I can tell you that many patients in Europe are smokers, and the infection rate is no higher in Europe than we see in the United States, and they do not make a significant effort to stop smoking in Europe. So most evident in reduction of wound-related complications probably in smoking. There's a poorer vascularity, so clearly in areas of wound healing it likely makes the biggest difference. It's not just enough to warn them. We do have to probably check up and do nicotine screening. Alcohol and drug abuse really have difficulty in the post-operative period with pain control. Can impact patient satisfaction scores. This is what sometimes we most commonly see as patients complain that their management of pain was very poor after their operation. Most of these patients were on narcotics before surgery. There's also a higher risk of these in-hospital complications in this population as well, with pneumonia and PE. So as I mentioned before, perioperative hyperglycemia is important, and infection obviously remains a challenging problem for all of us. And it's not only the cost, but also readmissions can be somewhat debilitating on the system and on the healthcare environment in general. Patients returning to the OR, as I mentioned before, the hospitals and physicians will be somewhat penalized for that, but prevention is really the most important thing. And trying to modify what we can as best as we can. I'll skip a little bit of this. These are some just case examples of infected knee patients. I'm sure you can see other things, but we can even determine this from x-rays and intraoperatively looking at how the bone is lost. These are joint replacement patients where the implants have been removed, cultures obtained, and then spacer components. And in this case, this is a cement spacer that's been placed that has antibiotic in the spacer. Once the infection is cleared, we can go ahead and put the components back. This is another patient with an infection from Serratia. Again, implants removed, spacer components are placed. They kind of look like this. You can notice here they're kind of floppy. They're not real great in terms of function for these patients, but it gives them a space to have the components put back in after the infection is cleared. And we talked a little bit about local antibiotic carriers, but these antibiotic beads or antibiotic paste can be used in these situations. There's also fluid solutions that can be washed through the joint to attempt to remove glycocalyx and bacteria. They're kind of detergents, and this is gaining some popularity. But really the ultimate goal is eradication of the infection for the long term of the patient. preserving as much of the bone as we can and soft tissues. In the knee, the patella tendon is extremely important. This is highly vulnerable to injury, fibrosis with all these infections, and we often get an early plastic surgery consult if there's significant issues with the soft tissue envelope. So while the goal is important for limb preservation, there are patients that do need amputations, and this is a case of a patient that had an amputation after infections, and they can do fairly well with a prosthesis, and more modern prosthetic implants, external prostheses is still a viable option for some of these patients. And there's only so many debridements and revisions you can do really before somebody just decides to go ahead and have an amputation and have a prosthesis. This is an example of a hip approach. This is the direct anterior approach. I'm just giving examples of different topical dressings. This is a silver-coated dressing that some surgeons will use. There are other surgeons that may use a topical incisional wound vac or other types of sealant dressings that prevent bacteria from involvement around the skin and getting into the incision site. These are what spacers kind of look like for those who've never seen one of those. Some are very creative looking, others look like beads that are kind of poured into the hip. Others where there's multiple fractures, you can have these spacers put in with plates and cement. And then those kinds of patients often will get a complete replacement of their femur. So I'm going to skip a little bit of the Prostolac stuff. So there are a lot of bad spacers out there. What I mentioned before is that we're really working with implant companies now to try to design spacers that are patient-friendly so they can continue to participate in their jobs and stay as independent as possible during the course of treatment for infections. Other devices that we've tried in the operating room to try to minimize blood transfusion, as I mentioned before, tranexamic acid is important. It's generally given 1 gram before the operation starts and at the conclusion. So generally 1 gram pre and then 1 at the time of the incisional closure, and this reduces blood transfusion significantly in total joints. The Aquamantis is a device that was it's been around for quite some time now, but it's a bipolar hemosealant device that reduces bleeding by constricting blood vessels with the use of a heat probe along with saline irrigation. And then these are other items that can be given, medications preoperatively to reduce the risk of transfusion, and this is just a little bit more about that. And we're starting a program at UAB for blood conservation and trying to bring patients' hemoglobin up preoperatively. Again, this is our protocol we use. Does not appear to have any impact on DVTs and PEs, and in fact, a study out of Mayo Clinic shows you can use this medication readily on patients with a history of blood clots. Early intervention, again, is important, and these are diagnostic tools that can be used to detect early hematoma development. It's important to aggressively wash out and treat these patients as well. So these are the list of basically recommendations. These are something that I think about on every patient and have discussions with them as far as their risk for infection as best as I can present it to them, and that we do everything we can to try to reduce their risk. As I mentioned before, I think the future holds some interesting interventions such as coated implants. I think eventually we will get to that point. In Europe, they're using silver-coated implants now to reduce the risk of infection because silver is an antibacterial effect. There are other centers using medical honey coating their implants in Asia that's showing significant reduction of infection with that, and there are iodine-coated impregnated metal implants also in the Southeast Asian countries that have shown significant decrease in infections around those implants. I think detergents to clean the glycocalyx will be helpful in the past. Delivery systems will continue to be used to bring antibiotics into the wound and into around the implants. So the team approach is fairly large. I think everybody's involved with this. I think it starts with in primary care, and then the surgeon has to modify what they need to do as far as which patients to operate on, which ones don't get surgeries, and then certainly it's important to have everybody on board to work for the same goal of infection prevention. I don't think one doctor can do this alone, and it's really all these different various people participating, even through anesthesia with the timing of antibiotic administration and The type of anesthetic given, I think, is also important to reduce blood loss and timing of surgery. So I thank you for your attention. That's all I have today, but I would be happy to answer any questions. Thank you. Yes?
Do you use remote TVs to cut down on the number of people in the operating room?
It can. It's very difficult for someone observing. Is that what you're asking? So it is important to have observers in the operating room at times to see what the environment is. Many times they're actually there to see what else is going on at the time of the surgery. So otherwise it's very focused just on the operative field. So often we'll have surgical or medical visitors who feel very detached from the operation by just looking through a video monitor. So they don't get the same real experience of the operating room if they're not in the room. So we often will give them an option for video observation, but for the most part, everyone usually selects to be in the operating room. Yes.
A two-part question. The first part is with the staph epi and staph aureus, what fraction of the post-op infections are MRSA?
Of the staph infections? Yeah, it's highly variable from hospital to hospital, but there's probably about 20 to 25% that are resistant, either vanco-resistant staph or MRSA. So I think, and that varies from hospital to hospital.
The reason I ask is I'm a plastic surgeon, and in my practice I see people that have MRSA. And I see two primary different types. One is the MRSA that's sensitive to vancomycin oldmate, and then the other that's sensitive to tetracycline, sulfa, as well as vanco. And my question, and I know you're probably not in a position to answer it, is if we have that much MRSA post-operative as a fraction of the total staph infections, why is the recommendation still to use a cephalosporin instead of vancomycin and say minocycline post-op or sulfa post-op?
So in orthopedics, we have gone to recommend the use of a gram of vancomycin often with those kind, particularly if they swab and they're positive. You can screen them that way. If they have high risk for MRSA, such as they live in a nursing facility or they've had multiple procedures or they've just got out of the hospital, there are ways of identifying MRSA at risk patients. So I think adding vancomycin to those patients preoperatively is certainly reasonable. You have to administer it to them about an hour before the operation. That's the more difficult part. Or you could use a topical vancomycin. So in spine surgery, for example, they've noticed a significant decrease in MRSA by the use of a topical gram of vancomycin. And that study was repeated in pelvic surgery as well at UAB, actually, on acetabular fractures. They as well showed a significant decrease in topical use of vancomycin. The problem is there are sensitivities to vanco. It's not easily administered, so everyone's allergic to it because at one point they may have gotten it and they got red man syndrome and now they're allergic. So I think those patients are probably not allergic, but there are some other medicines. Doxycycline is another one they use orally. So yeah, I think vancomycin is somewhat of a difficult drug to administer, but preoperatively, if you feel comfortable giving vancomycin, if you think someone's high risk, then I would certainly suggest doing, adding a vanco to the cephalosporin. Yeah.
Do you have specific operating rooms you only do dirty cases in?
No, but I wish we did have something like that. But no, ideally we think that we are completely cleaned after each operation, certainly, and we do try to put the infected cases towards the end of the day. But we do not have dedicated operating rooms. Nor do most centers have specific operating rooms for dirty cases, no. Anybody else have anything?